Présentation va être avec le Dr D'Agostino. Dr D'Agostino a complété sa formation de médecin généticienne à l'Université McGill ainsi qu'un fellowship en neurogénétique à l'Université de Montréal. Depuis 2015, elle fait partie de l'équipe de génétique médicale du Centre universitaire de santé McGill. En 2016, elle a établi une clinique NF pour adultes au Centre universitaire de santé McGill. Elle a aussi contribué au volet pédiatrique de la clinique. Elle dirige présentement une étude sur les manifestations psychiatriques des adultes avec la NF1. Donc, sans plus attendre, je la laisse présenter sa conférence. So, I just double click. Oops, no. I think you just have to go. Oh. And I guess. How do I make it bigger? This one? Yeah. And this one. And then to go down, just the arrow, right? Yeah. Okay, so this presentation will be in English. So thank you so much for having me to contribute to this nice meeting with my presentation, which is titled Fertility, Contraception, Reproductive Options, and Pregnancy in Neurofibromatosis Type 1. This is a team effort. Dr. Ortenberg, whom you saw earlier on today, she was here, and I lead the neurofibromatosis clinic at the McGill University Health Center. Miss Fox is our genetic counselor. She provides genetic counseling to patients with neurofibromatosis type 1. And Miss Naumova is a student who is interested in the medical aspects of neurofibromatosis type 1, and she's working with us on some of our projects on the syndrome. A few words about our clinic. It was founded about 30 years ago by Dr. Ortenberg, and it now works as an ongoing diagnostic service, receiving regular referrals by multiple sources, including primary care physicians, but also specialists such as dermatologists, oncologists, surgeons, and neurologists. It runs weekly and currently follows more than 400 active NF1 patients, of whom about 200 are adults, for all aspects of their health. The clinic is in the medical genetics division of the McGill University Health Center, and one nice aspect of the clinic is that it offers continuity of care from conception till adulthood to patients with NF1, so we never let them go. The clinic, the management of the patients in the clinic harmonizes with the published guidelines for management of patients with NF1. Patients that are more complicated are followed together with colleagues in a multidisciplinary fashion, colleagues that belong to our network of affiliated specialists. They're also interested in specific aspects of neurofibromatosis type 1. I will revisit very briefly, we've been talking about this the whole day, the clinical manifestations and also the genetic basis of NF1. So now when I say NF1, it means neurofibromatosis type 1. We know that NF1 is a multi-system condition that occurs in about 1 in 3,000 individuals. So as rare genetic diseases goes, it's a fairly common rare disease. Inheritance is dominant, which means that each child of an individual with NF1 has about 50% chance of inheriting the disease. It is the most common hereditary tumor predisposing syndrome, and patients with NF1 require lifelong proactive clinical monitoring. This means that a diagnosis of NF1 has a tremendous impact on the psychosocial well-being and reproductive decisions of patients. Our body is made up of trillions of cells, many cells, and inside the cells there is the genetic information. This genetic information is organized in structures that are called chromosomes, and chromosomes are made of genes. Genes carry the information on how our body functions, develops, and also on what we look like. Every individual has 2 copies of each gene, one inherited from the mother and one inherited from the father. So every individual also has 2 copies of the NF1 gene. However, in patients with NF1, one of the 2 copies is not working properly because of a genetic change which is called a mutation. NF1 manifests differently in different individuals. However, the most common manifestations include darker skin spots, which are called café au lait spots, freckles. We could have tumors in the optic pathways, darker dots in the colored part of the eye. They do not affect vision, but they help the physician make a diagnosis. There can be bumps on the skin, which are called neurofibromas, learning difficulties, and skeletal changes, such as, for example, scoliosis. Today, with this presentation, we'll address the following topics, which are relevant for the management of adults with NF1. We'll talk about fertility and infertility, the indication and safety of contraception, the availability and the outcome of assisted reproductive options, and particularly we'll touch upon prenatal diagnosis and preimplantation genetic diagnosis, and also the impact that the diagnosis of NF1 has on the management of pregnancy. So one important point is that there is very little literature on this topic. So these are poorly studied topics in the field of NF1. So we'll make some general considerations and then zoom into what's specific for NF1 as much as possible. So fertility and infertility are important topics. Infertility particularly has important psychosocial, medical, and even economic implications. It is important to study this aspect in NF1, but again, there is not that much on the topic. So how do we define fertility? It is the capacity to conceive and to produce children. On the other hand, infertility is an inability of a couple to conceive after 12 months of regular unprotected intercourse. The distribution of infertility in general changes within age groups, but it is estimated to affect about 15% of the population. About 30% of cases of infertility remain unexplained. Now, there is observational studies that suggest that there are some lifestyle and environmental factors that may influence fertility. For example, advanced parental age, use of tobacco or alcohol, excessive engagement in exercise, strenuous exercise, body weight, stress, exposure to environmental factors, pollutants especially. There is not a lot of information about the impact of recreational drugs on fertility, but usually it's recommended to avoid these substances because of their general impact on health. Also, similarly, some sexually transmitted diseases may indirect affect fertility because they may predispose a woman to a condition which is called pelvic inflammatory disease that may also lead to infertility. There are also some medical causes of infertility, and these are classified into male factors, female factors, both female and male factors, and there is, like we said, as we have seen, there is a proportion of causes of infertility which remains unexplained. Now, there is some suggestion in the literature that NF1, the gene, and neurofibromin, the protein that is produced by the gene, is involved in fertility, in the function of the testes and of the ovaries. For example, we know that neurofibromin, the protein, is expressed in the developing testes and ovaries. Also, the fact that in girls, puberty starts a little later, and in women, menopause may start a little earlier, may suggest that the reproductive period of women with NF1, especially here women, is reduced. A study done in the 80s by a Swedish group, it's indicated here, Samuelsson et al., tried to quantify this reduction in fertility, and they came up with a number. They say fertility is reduced by a factor of 20% in patients with NF1, but they attributed this, there was evidence in their study, that this is to be attributed to social aspects rather than biological aspects. Meaning, for example, that patients that have an important burden of the disease, they have more complicated NF1, they may opt not to have children, not to build up a family. Therefore, there is evidence now that in NF1, fertility is normal. And I think the story that Gabrielle told us exemplifies that there were no difficulties in conceiving. So this means that if a patient with NF1 also has infertility, this should not be attributed to NF1, but additional explanations should be looked for and additional tests should be done to clarify what is the cause for this. So one way to approach this is first to act on those environmental and lifestyle factors which we talked about before. And so these are ways to optimize natural fertility. For example, in the years leading up to pregnancy, couples are recommended or advised on modifying certain lifestyle factors, such as, for example, they're encouraged to maybe favor use of condom to reduce the risk for sexually transmitted diseases. It's one of the suggestions. Or, for example, for couples that are actively planning a pregnancy, to time intercourse around the time of ovulation. So these are ways to optimize natural fertility. There are also treatments for infertility. These include drug therapy, surgery, various procedures, and one of them is intrauterine insemination or in vitro fertilization. And there is no evidence in the literature that there are specific contraindications in patients with NF1 that need to undergo this treatment to have them. So this is for the first topic. The second topic is a bit of a tougher one. It's about hormonal contraception. So contraception refers to methods to prevent pregnancy by interfering with the natural process of ovulation, fertilization, and implantation. There are many ways of achieving contraception. The ways, how can I say, tools or methods that help in contraception are called contraceptives. And there are many different contraceptives that are available. They are classified under the broad categories of hormonal, spermicidal, intrauterine, barrier, and also surgical. And they all have different success rate. From the point of view of NF1, one way I like to look at them is whether there is hormones involved or there are no hormones involved in a specific contraceptive that a woman wishes to use. The other important point here is that for every instance when contraception is considered, this is a decision that's taken together with the patient, with a couple, and this shared decision process also ensures that there is the method that is chosen is used consistently. Now, one example of non-hormonal contraception is the copper intrauterine device, also called IUD. The advantage here is that this system does not contain hormones and therefore has no hormonal side effects. It acts by modifying the internal surface of the uterus, and that reduces sperm mobility and also discourages implantation. This method may be used by women who want or wish to avoid exposure to hormones, for example, women that have a history of breast cancer. And the other important thing here is that, thing to keep in mind, is that women with IUDs can undergo magnetic resonance imaging safely. And finally, it's a method that can be used for for emergency contraception. So before we talk about the hormonal contraceptives, I wanted to very quickly review with you some endocrine bases of how the hormonal contraceptives work. The function of the testes and of the ovaries is controlled at the level of the brain by structures that produce hormones such as, for example, LH and FSH. These hormones stimulate the testes to produce testosterone and the ovaries to produce estrogen and progesterone. When a woman takes hormonal contraceptives, this creates in the body of the woman, in the blood, a low and steady level of estrogen and progesterone, or just progesterone, And this tricks the brain into thinking that the patient, the woman, is already pregnant. And so these two hormones, LH and FSH, are not released, and ovulation is prevented. So hormonal contraceptives act by preventing ovulation. And the presence of progesterone here also helps modifying the internal surface of the uterus, and then that also prevents the implantation. There are many different formulations. There are the oral formulations, that one that can be taken by the mouth, and that's the pill. And then there are transdermal formulations, intrauterine formulations, and some injectable formulations, and these are the ones that are made of progesterone. Hormonal contraception can also be used for emergency contraception. Now, there is evidence that these authors wanted to clarify the question whether hormones, and specifically progesterone, regulated or were involved into the growth of hormones. This question is generated by the fact that we have knowledge that neurofibromas, the cutaneous one, the superficial ones, often first appear around the time of puberty. They increase in number and size during pregnancy, and they may shrink after birth. We also know that progesterone level increases after puberty, so we know there is a link between the two. So this author, they studied 59 neurofibromas. They took neurofibromas that were removed from patients, and they looked whether there were hormone receptors. And they found that neurofibromas, the cutaneous one, the superficial ones, express receptors for progesterone, suggesting that this hormone is important in the growth of neurofibromas. These authors went as far as to suggest that perhaps antiprogestins may be considered for treatment of excessive, for patients that have many neurofibromas. But to our knowledge, there are no clinical trials about this available. This other group, on the same line, they try to answer the question whether hormonal contraceptives stimulate the growth of neurofibroma. So here they surveyed 59 patients that have NF1. Eventually, only 58 entered the study. And these are women of different ages that were taking contraceptives from a few months to 2 decades, so a variable amount of time, and different formulations. So what they found is that those patients that were taking the contraceptives in the mouth reported virtually no changes in what tumor means here, neurofibromas, or there was a slight increase in the size and number of the neurofibromas. However, those patients, 2 patients, a very small number, that had an injectable version of the contraceptives, and this is the progesterone that's injected, reported an important change in their number and growth of neurofibromas. So their conclusion is that oral contraceptives do not seem to stimulate the growth of neurofibromas in NF1 patients, while high doses of progesterone might stimulate the growth of neurofibromas and deserve more caution. Now, there have not been other studies that have looked at high number of patients on the topic and made any stronger recommendations about that. And if we look at the latest ACMG, American College of Medical Genetics, recommendations on the management of patients with NF1 as far as this topic is concerned, we're still relying virtually on these 2 papers that I showed you. Now, if we look in general at oral contraceptives, there's some general recommendations that are given to all women that take this, but I thought perhaps some are a bit more specific for patients with NF1. For example, in general, oral contraceptives are not indicated if there is a current, suspected, or a previous history of breast cancer, or if there is a history of hypertension. Similarly, more specifically for combined contraceptives, those that contain both estrogen and progesterone, they should be used with caution or sometimes are not indicated if there is a history of migraine headaches, because it it may worsen, or a previous history of stroke. There is also concern that use of contraceptives in the very young woman may reduce bone mineral density, may contribute to bone mineral density. This is somewhat controversial. The different studies show have different outcome. On the other hand, we know that the bone health of women that are approaching menopause is improved by the use of oral contraceptives for those women that opt to use the contraceptives. And also, there is a reduced risk of ovarian, endometrial, and colon cancer. As we have seen before, for the injectable form of progesterone, there is a concern that they may lead to an increased number of neurofibromas, and also concern about bone density loss. This is especially in the young woman, in the woman that's approaching menopause or is around the menopause period, or in the woman that has reduced mobility. Again, different studies have different outcomes, and whatever effect these hormones may have on the bone health, it appears to be transient. It improves when the medication is stopped. For other formulations of contraceptives, in general, the levels in the blood are a bit more variable, and so they're considered to be safe, but there is less data that are available about these contraceptives. As for emergency contraception, this is based on the use of copper IUDs, or again oral formulations, and there is no known specific contraindications in NF1. So in summary, as far as the contraceptives are concerned, we have limited data on the safety of contraceptives in women with NF1. We know that they are overall, there is evidence from the information we have so far at hand that they are overall safe, with some caution to have when the injectable version of the progesterone is considered for use, because it may lead to an increase in the number of the neurofibromas. However, if pregnancy is not desired, contraception should be used. And if oral or depot contraceptives are needed to treat a medical condition, they should be used, because the advantages of using them likely outweigh any concern. The next topic that I just want to touch upon is that of assisted reproductive options. So we'll talk about prenatal diagnosis and preimplantation genetic diagnosis. Prenatal diagnosis is, both of these options are available to patients where the mutation is known. This is a review of the anatomy of the pregnancy. We see that the baby is surrounded by the amniotic sac, and the amniotic fluid, this bluish color here, is contained inside the uterus. And here is the placenta, that is the organ that gives oxygen and nutrient to the baby through the umbilical cord. The placenta is thought to have to contain the same genetic information as the baby. One of the prenatal diagnostic techniques is amniocentesis. In amniocentesis, a physician, under ultrasound guidance, take out a small amount of amniotic fluid from the woman's womb, and send this fluid. This fluid is then sent to the lab for analysis. Small amount means 1 to 2 tablespoons. In chorionic villus sampling, on the other hand, it's a teeny tiny piece of the placenta that is retrieved and then also sent to the lab for analysis. Also, this requires an ultrasound guidance for the technique to happen. As we have mentioned, as I've said, the placenta contains genetic information from the baby. This table compares the advantages of the two techniques. Chorionic villus sampling, also called CVS, is the advantage of that it can be done very early in the pregnancy, from the 11th week of gestation, usually around the week 11, 13. This means that the pregnancy is still what we can consider like a private pregnancy. So it could really be just a decision between the woman, the couple, and the physician. And that's considered an advantage. There is a slightly higher risk for miscarriage in women that undergo CVS than in women that undergo amniocentesis. Amniocentesis is done a little later, around week 15 to 17, and the risk of miscarriage is lower than in CVS. When we look at this risk of miscarriage, that's about 0.5% for amniocentesis and 1% in CVS, which means that the vast majority of women will not have this complication. One other way to do a prenatal diagnosis is prenatal ultrasound. It has been reported in NF1, but it's not a reliable method because the disease manifestations are variable, and it could be feasible if there is a change, an NF1 related change that is significant in size, and this is very rare in the prenatal setting. So there are some case reports, but it's not used or recommended. So preimplantation genetic diagnosis has been around, it can be considered as an early form of prenatal diagnosis, and has been around for NF1 for the past 20 years, since 2000, the year 2000. One European center reports that large European center for referral for patients that are referred for preimplantation genetic diagnosis reports that NF1 is the third most common reason for which patients ask for preimplantation genetic diagnosis. As I mentioned, it can be considered as an early form of prenatal diagnosis, and it's used to analyze embryos for specific genetic mutations found in one or both parents. It offers an alternative for couples who wish to increase their chances of giving birth to a healthy child, but are unwilling to terminate an affected pregnancy or use a donor egg or sperm. This option has also amniocentesis and CVS, should be discussed early in the care of patients with NF1 so that they have the time to consider their reproductive preferences before starting a family. Here is an image that shows how preimplantation genetic diagnosis happens. Embryos are generated by in vitro fertilization. The genetic information is analyzed in one or few cells taken from each embryos, and then those embryos that are free of the known NF1 mutation, the mutation that has been found in the parents, in one of the parents, is then transferred in the uterus. One drawback of this technique, of this method, as we have learned also before, is that it's not covered by Medicare in Quebec, and every cycle of preimplantation genetic diagnosis may cost upward of $10,000. I've just learned that this is not just a Quebec situation, but also in other provinces, this technique is not covered, at least for NF1. Not all provinces, but definitely in British Columbia, I was told is not covered, and maybe elsewhere as well. So this picture shows, and this one shows how preimplantation genetic diagnosis complements in vitro fertilization. Ovaries are stimulated through hormones that are given to the woman, and when they are ready, and this is monitored by ultrasound, they are retrieved, fertilized with the partner's sperm, embryo development is monitored, and then very early in the embryo development, usually around day 5 to 7, a cell is taken and the genetic material is analyzed, and then the embryos that are found to be free of mutation are transferred into the mother's uterus. Evidence shows that analysis of the embryo, of the human embryo at this very early stage of development does not affect or changes further development during the pregnancy. Now, this the impact of preimplantation genetic diagnosis in NF1 has been studied by this group. They looked at over 150 cycles of preimplantation genetic diagnosis in couples with NF1, and they found that the proportion of couples that achieved at least one live birth during treatment was comparable to that seen in couples with other genetic disease. This is about 30% of positive outcomes. So the couple is able to conceive and then to give birth to a child that does not have NF1. The study also found that a definitive diagnosis of the mutation that's present in the patients, in the family, and then looked up into the embryo was higher for embryos that had from parents with familial NF1. The parents themselves had relatives with NF1. And also a definitive diagnosis was higher for embryos that were tested at centers that had a high expertise level in this technique. It's expected that continuous advances in this technique may improve live birth rates for patients with NF1, and also this option should also be discussed early with patients with NF1 so that preparations can be made. Now, what we need to keep in mind is that the success rate of preimplantation genetic diagnosis, as we have said, is about 30%. And we have said before that fertility in patients with NF1 is normal. So couples should be informed that the possibility to have a child is 30% compared to the outcome of 80%, which is the normal pregnancy rate in a couple that is fertile. The last topic is that of pregnancy. So finally, we have a pregnancy. Usually, it unfolds nicely in patients with NF1, but as we have heard before, it's possible that complications may arise, and these need to be monitored closely. Reasons to monitor the pregnancy closely include high blood pressure, poor fetal growth, low amniotic fluid level, pregnancy that is shorter than expected, a higher rate of C-section that is done in women with NF1. Sometimes pain management is less adequate for patients with NF1 than in patients that do not have NF1. And also, as we have seen before, there may be an increased in growth of cutaneous neurofibromas. And it has been seen that in a proportion of these patients, the neurofibromas regress after delivery. So at least one group formulated some guidelines for the management of women during pregnancy. It's important that women are asked detailed questions about their neurological function, and so they should have a good neurological assessment. If there is scoliosis, and this is important scoliosis, respiratory function tests could be considered or should be done to assess respiratory function. If there are large neurofibromas, they should be monitored for growth. Of course, ultrasound assessment of the baby should be done to monitor growth very closely. A consultation with anesthesiology may be considered before delivery, and if they are concerned about spinal neurofibromas, a spinal MRI may be done before pregnancy or even early during the pregnancy. And finally, it's important to review genetic counseling concepts with pregnant women with NF1 to review what are the chances of outcome of the pregnancy and also the variability of the clinical manifestations of NF1. So in conclusion, we have seen that fertility is normal in patients with NF1, and there are no contraindications to treatment for infertility. Contraceptives appear overall safe in patients with NF1. With there is, with the lingering question about caution that we may have to have in the use of depo-progesterone formulations. Preimplantation and prenatal and preimplantation genetic diagnosis are available options in NF1, and pregnant women with NF1 should be followed closely during their pregnancy. One thing that emerges by talking to patients and also colleagues from other centers and also reviewing the literature is that there is a need for more multi-center and collaborative studies to harmonize the approach on the reproductive options in patients with NF1. So if you have any questions. Mm-hmm. Mm.
Cycle and releasing cramps. And she has done chemo and radiation, and my concern is there, like, because you said there's no really, there's limited studies about the correlation and the effects of the pill on the developing and neural hormones. But if in your experience, is there like a link or complications related to patients that already had treatments, medication, and using the pill, because 15 years old, we're still not concerned about pregnancy,
Mm-hmm.
but it's going to come soon, and you have like in your experience with patients.
Mm-hmm. So your concern is about the impact of the pill on the skin manifestations or on the other complications that she has had?
And also because you explained there's different kinds of pills and
Mm-hmm.
actions that have more progesterone, and you said like progesterone raises the cases of other cancers, and we know already that having chemo, radiation raises other types of chances
Mm-hmm.
to get other different types of cancers. So would that option like not be an option for her in this case? And I know I'm a bit off topic, but since we're talking
about oral contraceptives. So there is a concern about, the only concern that exists right now, it's about the injectable form of contraceptives, and because they have a higher dose of progesterone. There is no evidence for the use of contraceptives, the pill, in patients with NF1, and there is no evidence that taking the pill increases the risk of other cancer, especially breast cancer, which is important, especially for women with NF1. However, there are general contraindications, and those can be discussed with the endocrinologist. One thing that perhaps can be suggested is to, perhaps one thing that I would consider for a patient in my clinic at this age is to do a baseline bone mineral density, and then this can be followed up over time. But again, this can be discussed with the endocrinologist. So right now, I think I was also reassured by going through this information. It's frustrating that we do not have more larger studies to kind of corroborate what's already there.
Because we're trying
Yeah.
to fix one problem, but
Mhm.
raise or aggravate other situations.
So right now, besides this concern about the high dose progesterone, there doesn't seem to be any link with worsening of other conditions in NF1.